Finally, I would like to share with you an overview of TGI's TRULO study. Long-term success of kidney transplantation is far from optimal, and several of our speakers have highlighted this. They've also highlighted that immunologic rejection is a major cause of graft failure. In stable patients, subclinical immune injury is a key early contributor, often leading to graft damage, as outlined by Dr. Friedewald. And routine monitoring with serum creatinine, DSA, therapeutic drug monitoring is insensitive and nonspecific. Some centers rely on surveillance biopsies, as we've heard, but others wait for clinical evidence of graft injury to develop before exploring further. TruGraf was developed to provide a non-invasive monitoring tool to rule out silent or subclinical rejection and as an alternative to surveillance biopsy. Tract was developed to provide a non-invasive monitoring tool to rule out clinical acute rejection in patients with suspicion of rejection. However, relatively few of the subjects in the validation cohorts for these biomarkers were post-transplant more than a year, and there is relatively little data on serial utilization of TruGraf and Tract Testing to guide patient management and to look for synergies. Therefore, the study objective of TRULO is to evaluate post-transplant clinical outcomes in recipients of kidney transplants who are undergoing TruGraf and Tract monitoring. The primary endpoint will be a composite of the first occurrence of biopsy-proven acute rejection on a for-cause biopsy during the primary study period, which is 2 years, or a decrease in the estimated GFR of greater than 10 milliliters per minute at the end of the primary study period. Key secondary endpoints will include each component of the composite above. In addition, we'll look at the change in eGFR from baseline, which may be up or down from enrollment to the end of the study period. We'll also look at the proportion of biopsies with rejection at 2 years, the incidence of proteinuria, which we will define in the full protocol using total urine protein or urine protein creatinine ratio or microalbuminuria, something along these lines. The appearance of de novo DSA will be looked at 2 years, as well as graft loss and patient death. The study design is a prospective, multicenter, observational registry study. It'll be a 2-year primary study period. We will consider a long-term follow-on extension at the end of the 2-year period, depending upon the study analysis. The planned study size is 2,000 patients, and this will be done in approximately 40 to 50 U.S. centers. Trial procedures are as follows. Subjects will undergo TruGraf and Tract testing every 3 months for the 2-year primary study period. And in addition, subjects will undergo Tract testing at times of suspicion of clinical rejection. Clinical data collection at enrollment in every 3 months is fairly standard for observational studies, and we've minimized this to reduce the data collection burden, demographics, transplant information, rejection information, biopsy information, so on and so forth. Importantly, we'll only collect limited con meds, that being just the immunosuppressive meds, and no AEs or SAEs will be collected, as this is an observational study with no mandated treatment profiles. So all of the adverse events will really be that of routine care. Serum chemistry, chemistries, and the HLA antibody and BK viral loads will round out the data collection. As I said, it's an observational study without protocolized interventions, but this is the suggested use of TruGraf for a kidney transplant recipient, something you've probably seen in other situations. If the TruGraf test is a TX, then probably repeat testing in the 3-month interval of the study would be in order. If it's a not TX, non-TX, then perhaps you'd want to repeat it a priori in 4 weeks, and then so on and so forth down the algorithm. But not to belabor this, but it's not really mandated that this be followed. Tract testing is also reasonably standard at times of suspicion of rejection. Then cell-free DNA will be measured, and these are the thresholds for the ViraCore cell-free DNA product Tract. Key inclusion exclusion criteria are shown here. Subjects must be a minimum of 18 years old. They must be a recipient of a primary or subsequent living donor kidney transplant. And they must be at least a year post-transplant, again, focusing on this period of slightly more remote from transplant than in the previous studies. They must have a stable serum creatinine, which is defined as a creatinine less than 2.3 and a less than 20% increase compared to the average of the three previous serum creatinine levels. They can be treated with any immunosuppressive regimen, and they must be selected by the provider to undergo TruGraf or Tract Testing as part of the post-transplant care. Lastly, the subject needs to have primary Medicare coverage. Key exclusion criteria are shown here. Patient can't be the recipient of a combined organ transplant with an extrarenal organ or islet transplant. It can't be known to be infected with HIV, known to have nephrotic proteinuria, and known to have BK nephropathy. Thank you for your time and for participating in our symposium today. We know that these are challenging circumstances, and this has been new to everyone. If you are interested in learning more about any of the presentations that you've seen here or about the TRULO study, please contact me at the email address shown on the last slide. Thank you very much for your participation.